Welcome back to the Best PT Podcast. This is episode 4.12, talking all about the electrocardiogram, the ECG or EKG. Before we begin, I'm going to plug two things. You can also find these in the outline. I'm going to plug a book called Clinical Exercise Electrocardiography by the author Shel Levine. This is a great book. Shel Levine was my mentor in undergrad, taught me everything I need to know about exercise physiology as well as interpreting EKG very well. I think the book is about $36 on Amazon. Has a lot of input from PTs in there as well, co-authoring different chapters. I also have a separate video EKG lecture link in the outline that I did for my class 2 summers ago when we were taking EKG in PT school. So with that being said, let's begin. The procedure of an EKG is that a 12-lead EKG provides 12 views of the heart. So make sure the patient has clean skin and remove hair if possible first, especially for guys. Electrode placement, we have limb leads and chest leads. So limb leads, the right arm lead should be placed over the infraclavicular fossa, media to the right deltoid. The left arm lead should be placed in the infraclavicular fossa, medial to the left deltoid. The left leg lead should be placed at the left abdomen below the rib cage, and the right leg should be placed at the right abdomen below the rib cage. This is the grounding lead. There are 6 chest or precordial electrodes to place. V1 is placed at the 4th intercostal space along the right sternal border. V2 is placed at the 4th intercostal space at the left sternal border. V3 is placed midway between V2 and V4, with V4 being placed at the 5th intercostal space at the midclavicular line. V5 is placed along the left anterior axillary line at the level of V4, and V6 is placed at the left mid-axillary line at the level of V4 and V5. So these leads should start at the upper chest and wrap their way down the left side of the body, with V1 being on the right sternal border. Lead outputs. Lead 1 tells us the electrical results of the left arm and right arm leads. Lead 2, the left leg and right arm leads. Lead 3, the left leg and left arm leads. AVR is a combination of the right arm, left leg. AVL, left arm, left leg. And AVF, left leg, right arm, left arm. Interpreting waveforms on an EKG. The P wave tells us about atrial depolarization. The PR interval tells us the time that conduction takes to move from the SA to the AV node. Normal is 0.12 to 0.2 seconds. The QRS complex tells us about ventricular depolarization and atrial repolarization. This should take 0.06 to 0.1 seconds. The QT interval tells us about ventricular depolarization and repolarization. This should be 0.2 to 0.4 seconds. This will speed up during exercise and slow down during rest, but should still remain between 0.2 and 0.4. The ST segment normally should be isoelectric, meaning no deviation from 0. It is the isoelectric period following ventricular depolarization. And finally, the T wave tells us about ventricular repolarization. Interpreting sinus node rhythms. Normal sinus rhythm, the one that we hope everyone has, follows a PQRST rhythm with the heart rate between 60 and 100 beats per minute. Sinus bradycardia also follows PQRST with a heart rate less than 60 beats per minute. The sinus tachycardia, PQRST, with a heart rate greater than 100 beats per minute. Sinus arrhythmia, PQRST, with beat-to-beat variations in heart rate. And finally, sinus arrest is the occasional complete absence of a P wave or QRS complex. Atrial arrhythmias. We have premature atrial contractions. This is where the P wave shows up where they shouldn't be. Atrial flutter is when the atria beat 250 to 350 beats per minute. And the EKG shows sawtoothed P waves. Atrial fibrillation is when the atria beat 350 to 600 beats per minute, and there is no discernible P wave on the EKG. Atrioventricular conduction blocks. We have a first degree AV block. This is where the PR interval is greater than 0.2 seconds but remains constantly long. There are two different types of second degree AV blocks. There is Mobitz 1 or Winky-Bach, where there is a progressive increase in the PR interval until a beat drops off. There is Mobitz 2, where the PR intervals are normal, but there is an occasional or multiple missed beats. A third degree AV block, or a complete block, is where the atria and ventricles are being paced independently. This is a medical emergency that requires a pacemaker. Ventricular arrhythmias. We have premature ventricular complexes, or PVCs. This is where there is a P wave absence with a wide, bizarre QRS complex. There is bigeminy, where every other beat is a PVC, and trigeminy, where every third beat is a PVC. Ventricular tachycardia, or VTAC, is where 3 or more PVCs occur consecutively with a ventricular rate greater than 150 beats per minute. Again, P waves are absent and the QRS complex is wide and bizarre. Ventricular fibrillation, or VFib, is where ventricular beating is uncoordinated and they pulsate wildly. No cardiac output is present and the patient usually becomes unconscious. This requires immediate defibrillation. Ventricular asystole, or flatline. So this is where the patient is technically dead. They require immediate CPR and defibrillation. Myocardial ischemic or infarction rhythms. So ST segment depression can indicate a heart attack, but can also indicate digitalis toxicity or hypokalemia. ST segment elevations are the earliest sign of an acute myocardial infarction. Q waves, a long, greater than 0.04 milliseconds, or large, greater than 1/3 the amplitude of an R wave, is characteristic of a myocardial infarction. And finally, T wave inversion occurs hours or days after an MI, and can occur with bundle branch blocks as well after a stroke. That's it for episode 4.12, talking about the electrocardiogram. Episode 4.13 will be the last episode in the cardiopulmonary system, talking about physical therapy interventions for the cardiopulmonary system. As always, the outline will be in the show notes. Thanks for joining me.